This is Dr. Erin Suydam, who is trauma and acute care surgical critical care attending surgeon at the Allegheny Health Center Network in Pittsburgh, Pennsylvania. She's the medical director of patient blood management and bloodless medicine program at Allegheny Health Network. Dr. Suydam is assistant professor, Department of Surgery, Drexel University College of Medicine, and medical student surgical clerkship co-director. She trained in general surgery at Medical College of Georgia in Augusta, Georgia, and in surgical critical care at the University of Hawaii in Honolulu. And she's been in practice for 10 years. Welcome, and thank you for bringing your presentation.
Good morning. I'm going to speak a little bit about bloodless surgery techniques and trauma particularly. I don't have any disclosures. And just a small background at Allegheny Health Network in Western Pennsylvania. We are a growing health system with multiple hospitals, including 3 trauma centers. So what I wanted to touch on today were just a little bit of overview of patient blood management principles in general and how we take those into account in trauma surgery, as well as a little bit about managing anemia. I'll try not to overlap too much with my co-speakers. And then to focus a little bit on coagulopathy in trauma and management strategies there, as well as managing hemorrhage in trauma. So as we all know, we want to focus on our patient and not the number. So we're looking at the patient's clinical symptoms and weighing every decision of transfusion with risk and benefit analysis. Obviously, honoring our bloodless medicine patients' wishes for no transfusion. But we want to focus on the patient's status with close reassessment and then address their coagulopathy to help stop any bleeding and to treat their anemia with other strategies besides blood transfusion when possible. We want to avoid iatrogenic anemia, as Dr. Frank touched on, which is a major issue in hospitalized patients, and avoid unnecessary blood draws. And when we are using blood products, we want to make sure that we're handling them appropriately and not wasting resources. And then most of our PBM efforts within our health system are targeted toward education of our fellow providers and assisting them with best practice by using our electronic medical record with best practice alerts and reminding them of transfusion triggers, and then auditing our performance and seeing where opportunities for improvement are. And obviously, our PBM program is encompassing the care of bloodless medicine patients as we go, and using the strategies we use for our bloodless patients for all of our patients to improve their outcomes. So as has been touched on in the last 2 talks, we want to make sure that we're treating anemia as an independent diagnosis and disease and not accepting it as an inevitable consequence of being in the hospital and having lab draws or having surgery. We know how common it is and how it's associated with increased perioperative morbidity and mortality. So we want to focus on treating anemia to optimize patients as outpatients prior to dire straits when they come into the hospital, whether it's for a trauma or a surgery. And we also use an iron protocol and with the additional vitamins for erythropoiesis and erythropoietin for patients who may not make enough endogenously, or for our bloodless medicine patients as well. And we do have a preoperative strategy for elective surgeries to help us optimize anemia prior to elective cases. And again, we know how important it is to eliminate unnecessary lab draws and limit iatrogenic anemia. And this is supported by the Choosing Wisely campaign, which is run through internal medicine to try not to duplicate tests and perform tests that are unnecessary. And as Dr. Frank mentioned as well, we can use point of care labs, pediatric tubes, or low fill tubes to limit the amount of blood we're drawing. We can get a lot of information from arterial blood gases, which may be able to eliminate other labs. And we want to try to, in our critically ill patients that we're using central lines or arterial lines, return any blood draw to the patient so that we're not wasting blood. So to get into some of the trauma-specific considerations, we know that coagulopathy is a major factor in our trauma patients, and this is something that needs to be addressed in addition to hemorrhage to stop bleeding. So, we've all heard of the vicious triad of acidosis, coagulopathy, and hypothermia, which is going to potentiate bleeding and make it difficult to stop. And this may be non-surgical bleeding with diffuse oozing or DIC or things that cannot be resolved with suture necessarily. So we want to be cognizant of acidosis and how common this will be in tissue injury and shock as the patient becomes hypotensive. And we know that this is exacerbated by normal saline. So we've really moved away from normal saline and really any crystallized resuscitation of patients who are bleeding, understanding that this is going to potentially exacerbate acidosis. But if crystalloid is needed, we would prefer LR to avoid hyperchloremic acidosis. And this also affects the clotting cascade, as many enzymatic reactions are pH dependent. So we want to try to keep that acid-base status within a normal range. We also know how hypothermia contributes to bleeding, both by causing platelet dysfunction, as well as also affecting enzymatic reactions in the clotting cascade. So it's important to keep our patients warm, both with active warming measures and warmed fluids. And we know that even at 33 degrees, which doesn't seem like very severe hypothermia necessarily, factor deficiency is down to about 50% of normal factor function. So we want to avoid hypothermia in our patients as well. We know that coagulopathy of trauma is its own entity, and that patients who have normal coagulopathy or normal coagulation and platelet function at baseline and may not even be on any kind of medications or supplements that could affect it, have coagulopathy and platelet dysfunction just by virtue of having a trauma or a traumatic mechanism. And we know some of why this is. As far as trauma-induced coagulopathy, we know that it dysregulates the protein C system, and that this is somewhat common. Up to a third of our injured patients will have trauma-induced coagulopathy. And these patients are shown to have higher transfusion requirements if they accept transfusion, as well as increased length of stay, ventilator days, multi-organ dysfunction, and mortality. So we want to make sure that we're looking for this in all of our patients, given how common it is, and make sure that we're addressing it. Similarly, in patients who have traumatic brain injury, up to a third will also have coagulopathy simply due to their traumatic brain injury. And platelet impairment is also extremely common, given the endothelial injury associated with traumatic injuries. And we know that almost half of patients may have this on admission, and almost all of them at some point during their hospital stay. So again, something that's very common and that we want to pay attention to and make sure we're on the lookout for to correct as possible. Additional factors that affect coagulopathy include alcohol intoxication, which can be associated with some of our traumatic patients and their mechanisms of injury, as well as dilution. We mentioned avoiding crystalloid and attempting to stop bleeding as a primary concern, as opposed to diluting the blood the patient has. And then a lot of our patients are older or have comorbidities and are on anticoagulants and antiplatelet medications. So another thing to try to address from the get-go to know if these patients need attention to those drugs and if they need reversed. And we know that liver disease affects coagulopathy, and that may be a comorbidity that your patient has. But to keep in mind that liver disease does not automatically mean that the patient is prone to bleeding. Because the anticoagulant factors are also affected, and the patient's dysregulation is hard to predict based on just an INR. Other comorbidities that our patients may have that's going to affect their coagulation status include kidney disease and uremia affecting platelet function, hematologic disorders, iron deficiency, which, as we know, is extremely common. So our trauma patients are going to have that just as much as all of our other patients. Malnutrition or poor nutrition, and then critically ill patients are going to have abnormal hemostasis. So if that is something that's affected the patient recently prior to their trauma, that's something to keep in mind. And as I mentioned, if kind of bleeding progresses and patients go into DIC, that's something to watch out for with fibrinolysis and hemodilution, as we've already mentioned. So our patients who are on anticoagulants and antiplatelets, our strategies are listed here as far as reversal of these medications. And here I've listed or highlighted our treatments that are not transfusion related. So these would be applicable to all of our patients, including our bloodless patients. So our gold standard for the reversal of Coumadin is prothrombin complex concentrate, and then vitamin K. So that's our first line therapy when available. For rivaroxaban or apixaban, we use FIBA, or factor inhibitor bypass activity. Prothrombin complex concentrate would also be an option. Or the antidote andexanet alpha, which we don't have available. It's somewhat prohibitively expensive, but it is on the market. We do have the antidote to dabigatran, which is the Praxbind, but in the absence of that availability, FIBA or PCC would be an option. And then for our antiplatelet drugs, we use DDAVP frequently, and I'll touch more on this in substitution for platelets. To help encourage platelet binding and avoid platelet transfusion. So we know that it increases platelet adhesion with von Willebrand factor, and there's been some digging into this to look at the effectiveness of desmopressin in treatment of platelet dysfunction. And we've seen that it is quite effective, reducing the need for transfusions, reducing blood loss and the risk of reoperation for bleeding. And it has not been shown to have a significant difference in venous thromboembolic events. So this is a safe and effective strategy for platelet dysfunction, which may avoid platelet transfusions. At our institution, we've studied this particularly in traumatic brain injury patients. It's not the degree of blood loss that's concerning, obviously, in traumatic brain injury. The patient won't necessarily, lose enough blood to be hypotensive, but the concern is the morbidity and the result of their traumatic brain injury if the bleeding progresses. And so we want to arrest traumatic brain hemorrhage early. And our strategy has been to evaluate them with viscoelastic testing. And if platelet inhibition is noted, we've treated this with DDAVP quite successfully, and we noted that adding platelet transfusion did not make any difference in the amount of platelet inhibition on our viscoelastic testing. So we generally avoid platelet transfusion and treat with DDAVP. One consideration is that this can lead to hyponatremia, which obviously may be a concern in patients with brain injuries and cerebral edema. So we want to take that into account as well and be sure that we're not dropping their sodium too significantly. So as I mentioned, our strategy is to use viscoelastic testing. We have TAG at our institution, and we get this on every patient with significant hemorrhage or hypotension and traumatic brain injury and assess the need for correction of their coagulopathy. In the setting of a patient who doesn't accept blood transfusion, we still have quite a few options. If the patient has decreased factor function, we could consider prothrombin complex concentrate or vitamin K. If the patient accepts cryoprecipitate, that may be an option if they have low fibrinogen. And again, if they have signs of platelet dysfunction, DDAVP would be our go-to in a patient who wouldn't accept transfusion. And then we also want to identify fibrinolysis or any development of DIC. And if that's happening, then we want to use tranexamic acid or TXA. Generally, we follow the crash study guidelines to treat anyone who's suspected of having massive hemorrhage with TXA up front with the loading dose. And then if they have fibrinolysis on their TAG, we may give the second infusion dose. We utilize platelet mapping with our tags, which again help us have more information about whether platelet inhibition is present. In a patient who is having an overall normal tag, which should indicate that the patient can make a normal clot, we again may give dd-ABP and avoid platelet transfusion if they do have platelet dysfunction and a significant head bleed or a significant bleed that we're concerned may progress to more significant hemorrhage. Platelet mapping in TAG comes in two varieties. You get these two pathways, arachidonic acid and adenosine diphosphatase, which are two platelet activation pathways. And we can find whether the patient has an abnormality in those pathways and has some platelet dysfunction that may be improved with dd-ABP. So moving on to a discussion more of hemorrhage, the most important thing about massive hemorrhage is to detect it and intervene early. So to stop bleeding, you need to recognize significant bleeding. And once that is detected, our pre-hospital staff, as I had mentioned before, is instructed to try to avoid crystalloid fluid, to avoid acidosis and factor dilution, which may both contribute to worsening coagulopathy and bleeding. We do utilize permissive hypotension in a patient with massive hemorrhage to avoid that pressure head on any clots that may be trying to form. As long as the patient is awake and talking to you, then they should be perfusing adequately and may accept a lowered blood pressure to avoid exacerbation of hemorrhage. You may have heard of the Stop the Bleed initiative, which is through the American College of Surgeons, which is educating and advocating tourniquet use when appropriate and how to treat bleeding with direct pressure or kaolin-based dressings or quick clot, any kind of hemostatic gauze that may be available. And we provide some of these supplies to the community. I know in our area, we've educated teachers, we've educated policemen, folks who work at museums or public institutions to have these materials available and to try to help stop the bleed before the patient can get medical attention. We do encourage them, obviously, to present to a trauma center as soon as possible or the nearest institution. And again, if you recognize or suspect massive hemorrhage, we give tranexamic acid loading dose pre-hospital, actually, our system utilizes. So often they've received it before they even get to us at the hospital. And then we want to promptly address any bleeding that we can surgically or with radiology. So if it's something that's amenable to interventional radiology, we want to contact them as soon as possible and get the patient to the radiology suite. Or we want to get them to the OR to stop the bleeding. Depending on the stability of the patient, laparoscopy may be an option even in trauma, which could potentially limit bleeding. But if the patient's truly hemorrhaging and hypotensive, most likely we're going to focus on damage control surgery, which is to pack or resect anything that's actively bleeding, tie off anything that's actively bleeding, and use hemostatic agents, which I'll touch on, to try to limit the bleeding and then get the patient to the ICU for stabilization and continued correction of coagulopathy, to avoid a situation where you're doing sort of unnecessary bowel resections or anastomoses or work that can be done later while the patient's cold and coagulopathic in the operating room and starting to have sort of diffuse non-surgical bleeding that can't be addressed with suture and needs to be addressed with warming and correction of coagulopathy. We do have the advantage of having cell salvage immediately available, so we can use this even in emergencies and patients who come directly to the operating room after arrival. So in our spleen patients or solid organ injury patients or mesenteric bleeding patients, we do have the option of using cell salvage, which is really helpful if that's available to you. So again, as far as recognizing massive hemorrhage, we want to recognize shock. So this may be as simple as the patient being a little bit sleepy or drowsy with altered mental status. If they're cold, obviously changes in vital signs are what we usually look for, but we know that those come late. So tachycardia likely won't be evident until the patient's lost up to a third of their blood volume already in class 2 shock. So ideally, we want to be hyper attuned and recognize shock before it progresses to hypotension, which is class 3 shock and up to 40% of blood volume loss. So again, recognition is key to act early. And obviously, a lot of these situations in the trauma bay are a bit chaotic. There's a lot of learners and people who are drawn to watch and see what's going on. And it can be a very full room with a lot of chatter and disorganization at times. So you want to make sure that you're very efficient, that there's a clear leader organizing the efforts and assigning tasks, and that you have a system of notifying the operating room or the interventional radiology suite to move patients very efficiently through this process and address their bleeding as quickly as possible. So we want early action. We want, again, to avoid crystalloid or hypertension, and we need to make sure that we have that coagulopathy in mind and what our efforts can be to address that. So in patients who do accept blood, these are some of the indications or things that we use to activate a massive hemorrhage protocol. Obviously, in patients who don't accept blood, these are still things that we want to be attuned to recognize massive hemorrhage. So the mechanism and severity of the injury, the patient's hemodynamics, evidence of active hemorrhage, either internally or externally. We do know, however, that a clinical assessment is a poor predictor of whether the patient's massively bleeding or not. We're not very good at just kind of guessing by the look of a patient. So we do use scores to help us identify patients who are massively hemorrhaging. Here we particularly use the ABC score, or the assessment of blood consumption, which I'll talk about on the next slide. And then understanding the need to act early is going to decrease our mortality. And if you do transfuse, it's going to decrease the overall number of products that you need to use, and obviously the cost. So our massive hemorrhage protocol includes this ABC score, which includes tachycardia, or pulse greater than 120, systolic pressure of less than 90, a positive FAST exam. So a FAST exam is a focused assessment with sonography and trauma, or in ultrasound, which we use in the trauma bay. We look in the pericardial region for any pericardial tamponade or presumably blood in the pericardium. And then we look in the right upper quadrant between the liver and kidney, and the left upper quadrant between the spleen and kidney for any evidence of bleeding, as well as in the pelvis for any fluid outside of the bladder, which would be concerning for hemoperitoneum. So a FAST exam is a very quick and easily available tool to determine if we think the patient has internal bleeding. And then the last criteria is penetrating trauma of the chest or abdomen or pelvis, which would be more likely to cause bleeding. So if the patient has 2 or more of those 4 things, that's a positive ABC score. Additionally, if the patient has persistent hemodynamic instability, or you know that you are going to the OR or the IR suite, or you're massively transfusing the patient, those are all indications that you have a massive hemorrhage and you need to activate your protocol to address it. So again, short of blood transfusion and bloodless medicine patients, we do potentially have cryoprecipitate as an option. We know that that's the most concentrated form of fibrinogen. So if the patient's fibrinogen deficient, it's the best way to correct that. Similarly, we talked about ddAVP and the usefulness to help platelets adhese and have better platelet function. And then we talked about prothrombin complex concentrate and FIBA as options in addition to vitamin K for coagulopathy or factor inhibition or factor deficiency, or dilution or consumption. Just to keep in mind, if patients have been on a lot of antibiotics, they may have a lack of vitamin K, or if they have gallbladder disease, those patients particularly may be deficient in vitamin K. And then we talked about the use of TXA, as well as cell salvage. I know we don't have available, we used to, but there are options for collecting blood from chest tubes. If your patient has a hemothorax and has a chest tube placed, there are containers that can collect that blood, and you can retransfuse that to your patient. And again, we review every massive hemorrhage protocol and every activation to have quality assessment of how we're doing and how we can improve in addressing our patients with massive hemorrhage. In the operating room, we have quite a few materials available to help with hemostasis, in addition to suture or resection or whatever procedure you're doing to resolve the bleeding. But for any residual oozing or coagulopathic bleeding, we have fibrin, we have Surgicel, we have wax, we have TXA that can be used exogenously or on the surface as opposed to IV TXA that we give. And we have multiple hemostatic options too, as far as electrocautery, argon beam, bipolar, all of these things to try to help stop bleeding. So our goals are to be efficient in reducing blood loss and act early and limit further functional damage, particularly an intracranial hemorrhage. We want to prevent further bleeding and further brain injury. And this will meet our SABM standard, which is to manage coagulopathy and use TXA when indicated, which is in all patients who have trauma and significant hemorrhage per the CRASH trials. And that our massive hemorrhage protocol includes guidelines for management of hypocalcemia, hypothermia, again, addressing coagulopathy and doing all the adjuncts of correcting acidosis to prevent our vicious triad or our other factors contributing to coagulopathy besides just abnormal factor function. Just had a brief sort of case scenario to try to highlight how we apply PBM to our patients. So in this example, this is a level 1 trauma patient who's a 70-year-old male who's fallen down a hill and presents with altered mental status, a scalp laceration, and he is on Coumadin. So that is identified. So when he first arrives to us, it's noted that he has altered mental status with the decreased Glasgow Coma Scale. His scalp laceration is noted, and in our workup, we find that the patient does have intracranial bleeding with a subarachnoid hemorrhage, as well as multiple fractures of upper and lower extremities. And initially, we note that he is anemic already with a hemoglobin of 10.7, and his Coumadin is working, and his INR is 3.4. So things that we want to sort of highlight and address, pre-hospital, the EMS or emergency services can address his scalp laceration, the external bleeding, with direct pressure or hemostatic gauze to make sure that we're limiting how much blood he's losing from a scalp lac. As we know, those can bleed pretty significantly because it's very well vascularized. Once the patient gets to us, we want to control that hemorrhage by repairing the laceration or again, controlling the bleeding from any external source. And knowing that especially a femur fracture can lose a significant amount of blood in the thigh, we want to make sure that his extremities are immobilized to avoid further blood loss. For his traumatic brain injury, we're going to get our viscoelastic testing to see what we can reverse as far as any abnormalities, but we know that he's on Coumadin with elevated INR, so we would give this patient prothrombin complex concentrate to reverse his bleeding. And then we would look at our viscoelastic testing to see if he would benefit from DDABP or any other interventions to help his bleeding stop. And then with his multiple orthopedic injuries, we know that this patient is going to require multiple operations to fix these fractures with the orthopedic surgeons. So we want to make sure that we're addressing and avoiding worsened anemia from the beginning. So we'll collaborate with our orthopedic colleagues to use all the intraoperative tools that are possible to limit blood loss in the OR. But we'll also avoid making this patient's anemia worse with excessive lab draws. And we'll make sure that we start treating his anemia from the beginning to try to help him recover and to limit the degree of anemia that he may have throughout his hospital stay in his multiple ORs. So as we all know, we've learned so much from the experience of caring for bloodless patients, which can translate to our patients who do accept blood. So for all of our patients, we want to have individual patient-specific treatment plans. So again, back to the first slide, we're focusing on the patient, not the numbers or the algorithms or what we've been taught or used to our whole careers. Each patient we want to assess individually and determine the risks and benefits and how we can treat that particular patient. And we want to focus on their clinical status. If they do have hemorrhage or trauma, we want to stop the bleeding as quickly and efficiently as possible. And then we want to, in addition to avoid worsened anemia with excessive lab draws, we also want to learn to somewhat tolerate anemia if the patient's clinically well and treat their anemia to help them recover. And all of this will decrease our complication rates, our length of stays, and our cost. And we know that this is a team sport for sure, working with our colleagues to see how we can best address any of the patient's issues to get them through as completely as and efficiently as possible. That is all I have.